Okay, I think we'll go ahead and get started. Good afternoon. My name is Jen Zampino, and I'm with Plexus Communications. Thank you for participating in today's webinar. This program is accredited by Medical Education Resources for physicians, nurses, and pharmacists. In order to receive credit for participating today, you must complete the online evaluation form. I'll be putting a link to the form in the chat section. There will also be a link to the form that will pop up on your screen once we close out today's webinar. And lastly, we will be emailing you a link to the form in the next 24 hours. Shortly after you complete the online evaluation form, you will receive an email from Certifier that will include a link for you to download your certificate. Please ensure when completing the evaluation, you provide the email address where you will want to receive your certificate. On the evaluation form, we have included some links to some helpful handouts for you to download, including a link for you to download a copy of the slide presentation. This activity is supported by an educational grant from Regeneron. Before we get started with the presentation, I'm going to launch two multiple choice virtual polls for you to respond to. Please take just a moment to read the question and choose one of the options listed for your response. Your responses are anonymous and much appreciated. Here's the first question. Okay, thank you so much. If you have any questions for today's presenter, please type them into the Q&A or chat section, and I will ensure that the presenter sees them. If you have a case or more detailed question that you would like to discuss with the presenter, please click on the little hand symbol, and I will unmute you so that you can ask your question verbally. At this time, I have the pleasure of introducing today's presenter, Dr. Sue Park. Dr. Park is a medical oncologist, associate professor, Division of Hematology Oncology at UC San Diego Moores Cancer Center, La Jolla, California. Thank you and welcome, Dr. Park.
Thanks so much, Jen. I'm also at the VA in San Diego, so nice to see everyone here. Going to talk about the latest evidence for immune checkpoint inhibitors in veterans with non-melanoma skin cancer, and this is an area that I specialize in. So here are my disclosures, and I believe Jen spoke about how to receive credit. And again, this is supported by Regeneron. So here are our learning objectives. Because you'll be able to get a copy of these slides, you can go through these. I just want to get started so we have enough time to cover everything. So first, we're going to go through an introduction and an overview of just about the incidence of non-melanoma skin cancer and why it's important. So non-melanoma skin cancers, as the name implies, is any skin cancer that is not a melanoma. I feel like, a lot of us are more familiar with melanoma because it gets so much attention, but there's a lot of great changes that are happening for non-melanoma skin cancer. And the incidence is pretty high. There's an estimated 7.7 million cases worldwide, and this has been increasing, an increase of 33% from 2010 due to a lot of factors. And the most of the non-melanoma skin cancers that we see are keratinocyte carcinomas, and these are named just because of the skin cell they are derived from, the keratinocyte. So the two most common ones are cutaneous squamous cell carcinoma and basal cell carcinoma. And basal cell carcinoma is actually the #1 cancer that's diagnosed worldwide. We just don't capture it very well because it's so common, and these cancers are not included in registry data. So non-melanoma skin cancer actually resulted in more deaths than melanoma, but I feel, again, like I said, most of us know more about melanoma. So basal cell carcinoma, most common cancer globally. It's about 50% of all the cancers in the US. While the mortality is low, if we don't treat it, it does tend to invade locally, so the morbidity can be high. For cutaneous squamous cell carcinoma, this is the second most common form of skin cancer. Both the cancer itself and treatment for the cancer can actually cause negative impacts on your quality of life, and we'll go through why. And this tends to be more aggressive than basal cell. About 8% of patients develop recurrence. The cancer tends to come back. And then 5% of patients develop metastasis within 5 years. So the cancer comes back in a distant area from where they originally had it, which means then it is stage 4. So risk factors for non-melanoma skin cancers. So the sun is the biggest risk factor for these types of skin cancers as opposed to melanoma. Because melanoma can happen in areas where the sun does not see. So sun exposure leads to DNA damage. And then the DNA damage causes lots of different mutations that happen in the skin cancer cells. And then when you have lots of mutations, that causes a skin cell to go awry and then multiply. Having a family history of skin cancers is a risk factor. Also, if you have any type of immunosuppression, that's also an additional risk factor. So patients that have a solid organ transplant and they take medicines for their immune system so they don't reject the organ that they received, those patients are at extremely high risk of these types of cancers. And our veterans, they've likely had more occupational exposure to the sun, so they're at higher risk for these types of cancers. And they often report using sunscreen less, which is a protective factor. And most of the military population is male, and being male is associated with using less sunscreen. So how can we improve screening in our VA system? So I'm going to go through a case. So Maria is a 60-year-old retired Navy nurse, and she has a history of blistering sunburns during deployments in the Pacific. So when she was younger, she had pretty intense sun exposure to get blistering sunburns. And she presents today asking whether she should undergo routine skin cancer screening. So how would you respond to her request? And let's go through some of the data. So skin cancer screening for veterans. So the U.S. Preventative Services Task Force concluded that there's actually insufficient evidence to recommend for or against routine screening for skin cancer by primary care providers when looking at the total body. But honestly, this recommendation has been unchanged since 1996, so several decades ago. And this just tells us there needs, we don't have definitive research on this. There's still a lot more to be done. So right now, the data remains insufficiently explored. But because our veterans are at a high-risk population due to their sun exposure, and we don't know for certain whether, recommending or going against screening would help, we err on the side of caution. And we want to really consider educating the veterans on their personal risk factors. Are they immune suppressed? Do they protect themselves from the sun? Have they have a history of really bad sunburns? Comparatively see if we can improve their outcomes if we find cancers early. So I don't think that skin cancer screening is something we should not recommend. I think it is very individualized and it's very easy to do for the patient. So how would you respond to Maria's question? Do you recommend that I undergo skin cancer screening? And I'll let you guys all take a moment to vote. And looks like everyone got the right answer. So the correct answer is C. So current guidelines state there's insufficient evidence, but we can certainly perform one today, which is what I would recommend. So what challenges have you encountered when identifying or referring veterans with advanced non-melanoma skin cancer who may be appropriate candidates for immune checkpoint inhibitor therapy? And is there any screening process in place? We're going to go through another case, and we're going to go through Maria. So she undergoes skin cancer screening, like we had said would be good. And on her total body skin exam, you find a subtle small lesion, less than a centimeter, about 8 millimeters. It's along her frontal hairline. She didn't really notice it. So we do a biopsy of it by the dermatologist, and it reveals a well-differentiated squamous cell carcinoma. So what would we recommend to treat this skin cancer? So let's go through risk stratification. So these are the NCCN clinical practice guidelines in oncology on how to risk stratify cutaneous squamous cell carcinoma. So we used the location and size, what it looks like, if it's a primary lesion or if it came back, the patient is immunosuppressed, if they've had prior radiation, or if it's in an area of chronic inflammation like a burn, if the tumor is growing rapidly, if they have neurologic symptoms. We use all these to categorize if the patient will be low risk, high risk, or very high risk. We also look at pathology. So if you have any of these features, it is considered a low risk skin cancer. If you have any of these features, it is considered a high risk skin cancer. And if you have any of these features, it's considered very high risk. So for our patient, at least we know hers was, about 8 millimeters. So it's less than a centimeter, but it is located near her frontal hairline. So she would be in the high risk category because anything on the head or neck of any size could be considered high risk. These are just other staging systems. So the most common one that medical oncologists use is AJCC. BWH stands for Brigham Women's Health. This is another criteria staging system that is used. That's mainly used by dermatologists, but I also use it as well because I specialize in this disease. And then the Tübingen staging system is one that was developed in Europe that's not really used in the US. I just want to highlight that for basal cell carcinoma, which is the other skin cancer, there's actually no staging system for basal cell that's been developed. So if we want to go through the management algorithm for low risk squamous cell carcinoma or a high risk and very high risk, you can see here that for low risk, our main goal is to just remove it. So most of us will, refer them to a surgeon, whether it be a Mohs surgeon or a head and neck surgeon or some other surgeon. And the goal is to take it out completely, meaning that the patient has negative margins. But sometimes when we look at the pathology under the microscope, we see that the margins are positive. So if the margins are positive, we have several options. We can go back in and do surgery again to take out what is positive. If we can, sometimes we can't always go back in. The surgeon has some limitations. And if not, then we can just do radiation to try to, kill off any of the remaining cancer cells that are there. If the patient has a high risk or very high risk squamous cell skin cancer, nowadays, because the treatment landscape is changing so much, we really recommend consulting with an expert and having a multidisciplinary discussion, and also perhaps considering sentinel lymph node biopsy. But I would defer that to the multidisciplinary consult discussion because sometimes for very high risk or high risk skin cancer, it is appropriate to just go ahead to surgery. But sometimes there are things we can do before surgery, or there are other alternatives to surgery for patients who can't get surgery. And the treatment after surgery is largely the same as above. If you have negative margins, but the skin cancer was high risk to begin with, sometimes we'll recommend getting radiation after the surgery, just to make sure everything is, pretty clear, kind of like an insurance plan. But if you still have positive margins, then we want to go back in and take it out if we can, or we can sometimes do radiation. Or if we can't do either of those, and there's still cancer left, there may be other things that we can do, like immunotherapy. So for Maria, so we find this small skin cancer on her frontal hairline. So what would you recommend for treatment? So observation, topical 5-fluorouracil, which is a chemo cream, electrodesiccation and curettage, which is where they basically kind of like burn the lesion off, then like scrape it off. Would you get surgical excision with sectional assessment, or would you get Mohs micrographic surgery? So I think there's not one standard option or answer. So some people said topical 5-FU. Yeah, if the patient is like really old, sometimes we will consider this if it's within their goals. Surgical excision is appropriate too, because sometimes some patients, not all patients have access to a Mohs surgeon. If you do have access to a Mohs surgeon, because a lesion is on the face, Mohs surgery is a special type of surgery where they will go by sections and stages, little by little, to take the cancer out, but take as little of the healthy tissue out. So only special dermatologists who have special training can really perform this, and not everyone has access to this. So I think all the answers that people chose would be reasonable depending on patient context. So now we're going to talk about immune checkpoint inhibitors for treating advanced non-melanoma skin cancer. So we'll go through a patient case. So you'll meet James. He's a 70-year-old Army veteran. He's a former combat engineer. He's had multiple prior skin cancers. He presents actually with a rapidly enlarging right submandibular mass beneath a previous excision site. So because we know that there's a previous excision site and he has something growing rapidly, I can safely assume that something has come back. So this is something recurrent. He has hypertension, hyperglycemia, and hyperlipidemia. He's married and has an adult son. So when I examine him, I find that he has extensive sun damage and he has a well-healed scar at the previous surgical site on the right jawline. And then I can feel a 2-centimeter firm mass in the submandibular space. I don't feel any other lymph nodes. And so we put a needle in it to get a sample of what this mass is. So a fine needle aspiration demonstrates atypical cells consistent with squamous cell carcinoma. So what would you recommend for the next steps in management? So NCCN guidelines state that, when you do have a patient that comes with a new mass, we want to take a better look at it, not only with exam, but imaging. Imaging will help us see how deep it is, if it's involving other structures, or also if it's spread to somewhere else. So due to the higher sensitivity, if you are concerned that there's like deep soft tissue involvement or particularly nerve involvement, so if you're examining a patient and they have trouble smiling or their eye is a little droopy, MRI is really best to look for nerve involvement. But if you want to take a good look at the lymph nodes, or if you think maybe the skin cancer has penetrated the underlying bone, then CT with contrast is really good to look at this. So the type of imaging that you use and where you image should really be at the discretion of the team that's treating you based on how far they think the disease has spread. So if I feel like the disease is really advanced, I might want to examine and get imaging of the entire body just to make sure it's not metastatic. So what would you recommend for next steps in management? Would you get imaging? Would you go ahead and get a biopsy? Would you go ahead and do a lymph node dissection or radiation therapy or immune therapy? So I probably would get imaging just to see if there's anything involving like muscle or bone. Eventually, we probably will also need to get some type of biopsy. I think in the past, excisional biopsy was one way we could have also dealt with it, try to take it all out, but the landscape is changing and we can learn what else could be we offer patients. So we do get a CT and it shows that there's only this solitary 2-centimeter submandibular lymph node. So we don't see any other signs of anything in the chest, nothing else in the neck. So just this one area. So what would we do next, or what can we consider? So this is where it's really important to talk about the multidisciplinary skincare team, because nowadays with immune therapy helping so many patients out in earlier treatment settings, we really need to involve a medical oncologist early on. So advanced cases sometimes need multimodal therapy. So they need to see a dermatologist, radiation oncologist, surgical oncology, but I think most importantly, they really need to see the medical oncologist because we're kind of like the quarterbacks for directing the care. We often know what clinical trials are out there, and we also know how to use immune therapy in earlier settings outside of a trial, so we can already help patients and they don't actually have to be on a study. So there's lots of different things we think about whenever we're considering immune therapy. So, we think about the patient's comorbidities, procedural and logistical factors, where the tumor is, how big it is, how good your surgeons are, how confident I am. Can they get radiation or again or not? Some patients have already gotten radiation before. They have contraindications to radiation. And how distant or far along has the cancer spread? Is it just in one area or are there other lymph nodes that are involved? So I try to see a lot of patients with high-risk skin cancer. I have a lot of them sent to me first, so that we can see if they would benefit from all the new data that's coming out. So I just want to go over for those of you that are not, too familiar with the medical oncology world, how, what immunotherapy actually is. So this is basically a cross-section of what your skin layer would look like. And here we have the sun, and we're exposed to the sun all the time. The sun causes mutations. So here the sun is causing a mutation. And whenever cells get mutations, they tend to grow faster and proliferate. So here you see that there are these skin cells that have gotten probably a mutation from the sun. They're starting to grow and proliferate, and they continue to proliferate and make more copies of themselves. And then eventually, some of the skin cells get so many mutations that they actually turn into from a skin cell to a skin cancer cell. So here you see these cells that are colored, that look a little abnormal. Those are skin cells that have accumulated so many mutations, they have turned into skin cancer. So here we have a cell that has come in. These are immune cells that we have in our body. And here we have a T cell. The T cell is in blue. And the black cell is just another immune cell that has come, because immune cells come to try to get rid of the cancer. They're, watching our body when we're sick. They also try to watch our body when we have cancer. But the problem is this T cell is linked to the immune cells. And whenever they're linked, the T cell is not very active. So here you can see the T cell on the right, and then we have another cell on the left here. So you can see that the cancer cell is on the left. The PD-L1 on the cancer cell is engaged with PD-1 on the T cell. So when they're engaged, the T cell on the right is not active. It's basically staying quiet. So there were some researchers that thought if you could block this interaction, block this PD-L1 binding to PD-1, so blocking the cancer cell from binding to the T cell, then the T cell would kind of wake up and not be quiet, and the T cell can do its job of getting rid of foreign cells. So right now it's showing that whenever the T cell is linked to the cancer cell, that the T cell turns gray. It is inactive. It's not working. It can't tell that there's cancer right there. But these wide-looking things, these are the antibodies that we use. These are the immune therapy drugs that we have. These drugs block this interaction. And so what we see is that the T cell now turns blue. It becomes active. And when T cells become active, they also activate other cells. So the cell that was black has now turned blue as well. And then they can attack the cancer. So basically, immune checkpoint inhibitors block the PD-1 to PD-L1 interaction to make the T cell kind of go from an inactive state to an active state to attack the cancer themselves and also activate other immune cells to attack the cancer. So let's go through some of the data for immune therapy for locally advanced or metastatic disease. So if you have a patient that has really advanced squamous cell carcinoma, the standard of care is now immune therapy. We don't use chemotherapy anymore for this disease. So there's 3 different drugs that are approved for squamous cell that's either metastatic or locally advanced. There's cemiplimab, pembrolizumab, and cosabelimab. And what you can see here is they work pretty well, especially for patients that have really advanced disease. About half of the patients will respond. And some of the patients, even the disease completely goes away. That's what is known as a CR or a complete response. And there's a decent number of patients, around 30%, where they have a partial response, meaning that the drug is able to control the cancer and make it smaller for some time. So in oncology, when we find drugs that tend to work pretty well in patients that have locally advanced or metastatic disease, what we like to do is bring it earlier into the treatment space to see if we can help patients, more patients, and also patients that don't have metastatic disease. So this is the case here. So instead of locally advanced or metastatic disease, can we use immune therapy to help patients with high-risk disease, but resectable disease, meaning that they would still be a candidate for surgery so it hasn't spread everywhere? So this was a study that was conducted several now, I think it started in actually 2020 and they published it in New England Journal of Medicine in 2022. So they took patients that had stage 2 to 4 resectable squamous cell, and specifically for squamous cell of the head and neck, just because we label you as a stage 4 does not necessarily mean you have cancer in other parts of the body far away. Stage 4 can also mean you just have a lot of lymph nodes in the area close to the cancer. So they took 79 patients, and instead of just having them go to surgery first, which they could have done, they gave them 4 doses of an immune therapy called cemiplimab, and then they got surgery. And then after surgery, they could have either gotten more immune therapy, or they could have gotten radiation, or they could have just been watched and got nothing. So they had actually 70 of these 79 patients go to surgery. And after surgery, the pathologist looked at what was taken out under the microscope, and you can see that 51% of the patients had no cancer left after they got 4 doses of immune therapy before surgery. An additional 13% of patients had a major response, meaning that the pathologist found 10% of tumor or less in the specimen. So this is a really high rate of having no cancer left or very little cancer after surgery if you got 4 doses of immune therapy first instead of going to surgery alone first. They also did CT scans on these patients, and you can see that even though there was a high rate of having no cancer left after the surgery, if you got immune therapy, sometimes on a CT scan, we can't really tell, but we know that because those patients went to surgery, that a lot of them did not have cancer. So what we see on a CT is not always what we see on pathology. Sometimes it can look like on a CT scan or an MRI that there's still a little bit of cancer left, but that could just be, changes in the fat planes from the cancer getting smaller. It could be fibrotic areas. It could be a lot of different things. So just because on a CT or an MRI, you see that, you may think that there's still a little bit of cancer left, or you don't think that there's, it doesn't look 100% clean as the tumor looks like it's gone away 100%. A lot of the times the tumor is gone and you need to confirm with pathology. So radiology does not always tell you what you'll see in pathology. So I want to turn your attention to the areas in red. So in the patients that had a PCR, so PCR means those patients after 4 doses of neoadjuvant immunotherapy, when they got surgery, that they had 0% cancer. So it's been about, 3 years now of follow-up, and there have been no patients that have had their disease come back. And if we look at the patients with a major pathologic response, the ones that have 10% or less of tumor, they had 1 patient and it came back in, but that 1 patient had a big tumor and a lot of lymph nodes. And that patient was chosen not to get anything after the surgery. They were just watched. So that patient probably needed radiation after surgery, but these are still really good numbers. So if you have a path CR, so no cancer left in the surgery specimen after getting 4 doses of neoadjuvant therapy, your chances of having the cancer come back are really low. And a lot of these patients actually were just watched. They did not get anything after the surgery. This was another real world study that was done out of 2 hospitals in Boston. And they gave, out of 291 patients that were treated with some type of immunotherapy for squamous cell, they found that 27 of them got treatment neoadjuvantly. So they got the immune therapy before surgery. 16 of those patients had some type of radiology exam, like a CT or MRI. And then 19 patients had pathologic specimens. So 19 patients actually went to surgery. And you can see most of the patients got cemiplimab, 5 got pembrolizumab. You can use either drug. They're both approved. And they looked at the radiology response rate and the pathology response rate, and they also looked at other endpoints related to clinical outcomes like recurrence-free survival. Did the cancer come back? How long have the patients lived without cancer? And how many of the patients are alive now, regardless of any reason. So you can see that the data is quite similar to the initial study. So you can see on the bottom side, the pathologic complete response. It's about 30 to 40%. So maybe a little bit lower, but this is also a retrospective look, but still pretty high. They had about 11% that has the major pathologic response, but you can see the numbers are much lower for radiology, which is, again, is what we see. What you see on a scan is not always what you see on pathology. Scans typically underestimate what you actually see after surgery. This is another study similar, just looking at giving another type of immune therapy, the same drugs, one of the same drugs, the PD-1 inhibitor, pembrolizumab, looking at it before surgery. And you can see that the path CR rate is still quite high. You can see that out of the patients they have here, which was 26 patients, a lot of them have the blue bars. This is also just another study, but this one was unique in that they tried to see if all the cancer went away on exam, and if you had a PET scan and the cancer went away, and if you had a small biopsy of where the cancer was and that was negative, maybe you actually didn't need to get surgery and you were just going to get more immune therapy for a defined period of time. And they saw that 48% of the patients in this study, so there's 27 patients, 48% of them had all the cancer go away on exam. The PET scan was negative, and when they took a small biopsy of where the cancer was, that was negative too. Those patients did not go to surgery. They just got 13 more cycles of the immune therapy, and all of them are doing well and have not had the cancer come back. And that was without surgery. So this is where the field is kind of moving, trying to see, what we can do to try to avoid surgery and also to try to avoid radiation. This was a similar study where they looked at giving some drug before surgery, but in this case, it was atezolizumab. This is a PD-L1 inhibitor, not a PD-1 inhibitor. They're still very similar, but perhaps the reason why the rate is a little lower, the path CR rate, is because it's a PD-L1 inhibitor. There are people that think PD-L1 inhibitors are the same or not the same. I tend to think they're a little different. And this drug is not approved for squamous cell anyway. But it's another interesting study that just highlights if you give drug before surgery, patients tend to do better. There was another study that was recently published that looked at giving 2 immune therapy drugs instead of 1. So looking at giving nivolumab and ipilimumab, which is the common treatment for melanoma. And, giving 2 drugs is pretty good too. But because the data for 1 drug is just as good, and sometimes giving 2 drugs can sometimes lead to more side effects, even though in the study, the side effects were not that increased and they were manageable. And this is also not FDA approved either. This was just a provocative study. I think current data at least just tells us giving something before surgery is better. And also the currently approved drugs that we have to do that are the drugs that are used in the advanced setting, which this regimen is not used in the advanced setting for squamous cell. So there are some patients that I see. So if it's better to give drug before surgery, I try to convince many patients of that, but there are some patients I can't convince, and that's okay. And so, those patients just get to surgery, and whenever this pathologist looks at their cancer under the microscope, they see a lot of cancer left. And sometimes they even see the edge of what was cut out to be positive. So then, this study was looking at giving immune therapy after surgery if you did not get it before surgery. And giving it after surgery actually helps the disease stay away for much longer. As you can see here, the curves separate early and they stay separated, meaning that if you got immune therapy after surgery, you had less of a chance that the cancer came back than if you got nothing after surgery. So if you weren't able to get immune therapy before, there's the opportunity to get immune therapy after surgery, and it can still really help you. And this is the only drug that's actually approved for this indication after surgery. So this drug was actually just approved in October. So it's really nice that we have another option. We have this option, the only option for patients after surgery. So after surgery, they would get radiation and then they get this drug for about a year. There was actually a very similar study that was reported around the same time using a different drug, pembrolizumab, in the same setting after surgery and after radiation if you couldn't get it before surgery. But this study was actually negative while the other one was positive. But the two studies, while they sound similar, when you dig into the data, they're actually really different. And we're waiting on the final publication of this study as well. So I think there are several reasons why this one was negative and the other one was positive. So if I do see a patient that they did not get immune therapy first, so they got surgery first, and then they had really high risk disease when the pathologist took a look at their cancer under the microscope, or they had certain other high risk features, then those patients will get radiation after the surgery, and then they have the opportunity to get 1 year of adjuvant immune therapy based on this C-post trial. So this is kind of where the field is headed. So patients that have really high risk squamous cell with a significant risk of the cancer coming back in the same area, or the cancer coming back in a lymph node, or having cancer that's spreading along the skin to other places, you really want to start with just the multidisciplinary discussion, because a lot of the time the medical oncologist will see these patients and talk to the radiation doctor and the surgeons, and oftentimes considering immune therapy first is, what can really help these patients. But obviously not all patients will, agree to that. And because our goal is to really try to, get negative margins, or to really try to prevent such a disfiguring surgery if we can. So back to James. So if you guys remember, he has cancer before that has come back. But it came back only in a 2-centimeter submandibular lymph node. But the fact that it came back means that it's high risk. The fact that it's on his face is also high risk, but at least we don't see anything far away. So what would you recommend for the next steps in management? Would you get a lymph node dissection? Would you start immune therapy? Would you do radiation, or would you do chemotherapy? So most people chose immune therapy. Radiation therapy is also sometimes an option in some patients. If this patient has a solid organ transplant, sometimes radiation, we can consider that, because those patients cannot get immune therapy. But for this patient, I probably would have chosen immune therapy. So he received 2 doses of immune therapy, and there's no data right now to say how many doses you could use. There was a pilot study that used 2, and then that pilot study informed the study I presented that was published in New England Journal of Medicine. That study used 4. He tolerated the therapy very well. These drugs tend to work really fast, so even after the first dose, the tumor often is noticeably smaller, and even after 2 doses, sometimes the tumor completely goes away on exam, even if it's a really large tumor. So he got 2 doses, then he went to surgery. And after surgery, the pathologist did not find any tumor in his lymph nodes, or in the primary area where the tumor was. So he was one of those patients that belonged in the 51% of patients that had a pathologic complete response. They had 0% tumor. So if this was my patient, I would not do anything after surgery. I would just watch him, and it sounds like he's doing well in active surveillance. So now we're going to talk about the other type of skin cancer, basal cell carcinoma, which is the most common skin cancer. Here's Linda. She's a 65-year-old retired Air Force pilot. She has a long-standing basal cell on the side of her nose, and it's about 3 centimeters, and it's ulcerated. It involves the nasal cartilage. It involves most of her nose, but spares the orbit. So it's involving her cartilage, so it's kind of deep. It involves most of her nose. That's an issue, but at least it's not involving her eye. And on exam, you see it's firm, it's ulcerated, it stops short of her medial canthus near her eye, it extends near her nasal tip, it butts her medial cheek, and it involves the dorsum of the nose. But there was no lymph nodes that you can feel. So we get an MRI, and it confirms that the disease is local, but on exam, it looks pretty extensive, but at least it's not involving the eye, which is good. So she's seen in the multidisciplinary clinic, and the surgeons see her and they say, yeah, we can help you, but we would probably have to take your entire nose out. And that's a pretty disfiguring surgery to anyone. So Linda asked if there's a way to avoid this. So let's discuss. So for locally advanced basal cell, again, just like squamous cell, I would do a multidisciplinary discussion. And, a lot of the times surgery will take care of these patients, but there are some instances like Linda where the surgery would be really disfiguring. Radiation is also a good alternative, but radiation can only be done in certain patients. And if the disease is really, really large or extensive, radiation may not also always be the best option. So if surgery or radiation are not really good options, then we also have systemic therapy available for these patients. So basal cell is a tumor that is typified by alterations in the hedgehog signaling pathway. And so if there's alterations in the hedgehog signaling pathway, a lot of times we use pills that are called hedgehog inhibitors for these patients. And this is what vismodegib and sinidegib is. These are pills that are hedgehog inhibitors that are specifically used for advanced cases of basal cell. But because they do a pretty good job of shrinking, basal cell cancer, the thought is that if you give it before surgery, you can shrink it and then you can make the surgery a little less morbid. There are some patients that get one of these hedgehog inhibitors and the cancer does get smaller, but then it becomes resistant, so then it stops working. Or there are some patients that start a hedgehog inhibitor and then they have really bad side effects and they can't take it anymore. So if you're one of those patients where you've tried a hedgehog inhibitor and it didn't work anymore, or you cannot tolerate it, then cemiplimab, which is one of the drugs that is approved for squamous cell, this is the only drug that's actually approved for basal cell that's an immune therapy. This is an option for you, but after you've tried a hedgehog and you either couldn't tolerate it or it didn't work. So this is just showing you the studies that both these hedgehog inhibitors, vismodegib and sinidegib, got FDA approvals on. So it would concentrate on the orange bars. So they work pretty well, 50 to 60% of patients, for patients that have locally advanced disease. If the cancer has already spread to other parts of the body that are far away, they tend to work less. But they tend to work pretty well, as in they shrink the tumor. And then if you look at the dark blue bar, the navy bar, the disease control rate means that they do a good job of, keeping the disease under really good control. But this only works while you're taking the drug. If you stop the drug, the cancer tends to grow back. And the other problem with these drugs, like with a lot of pills, is that you tend to, get resistance. And so sometimes a lot of these patients try to stay on the drug, but they can't because of side effects, or they can't because the tumor has become resistant and the drug is no longer working. So for Linda, what would you recommend? She has a pretty extensive basal cell on her face. Surgeons said that she would need almost a total rhinectomy. So would we recommend surgery? She could get radiation after surgery. Would you just start with radiation? Would you start with a hedgehog inhibitor, which is also sometimes known as a smoothened inhibitor? But hedgehog inhibitors is the more common terminology. Or would you consider immune therapy? So I probably would start with either a hedgehog inhibitor or immune therapy. I think her disease maybe is a little bit too extensive for radiation, but we can always, that's why we have a multidisciplinary team for the radiation doctors to see her. Some of you may wonder, oh, why would you choose immune therapy if she's never gotten a hedgehog inhibitor first? Because of what I just said, we typically consider immune therapy after hedgehog. But there are some patients that cannot get a hedgehog first. So hedgehog inhibitors are pills. There's some people that can't take pills. Maybe these pills can't be, ground up and given through a G tube. So there are some patients where we will start with immune therapy, but typically I would start with a hedgehog inhibitor. So she was started on one of these and she got it for 3 months, and the tumor is a lot smaller, 70%, but she's getting side effects from the hedgehog inhibitor. And a lot of these side effects are, most of them are hair loss, muscle cramping, and then taste changes. And they can be pretty bad. And a lot of these patients cannot stay on the hedgehog inhibitors for long term because of the toxicity. In the trials, they had like 50 to 60% of patients discontinue the medicine because of side effects. And that's a pretty high rate. So they try to keep her on it and do different dosing, keep her on the drug for 8 weeks, take her off the drug for 8 weeks. And she was able to tolerate that from a side effect profile and still control the disease for 3 years. But then 3 years later, she had another MRI that showed that the cancer was growing, even though she was taking the hedgehog inhibitor vismodegib. So she saw surgery again, and they agreed that, yes, they could still take the tumor out, but it would require them to basically take her entire nose out, which, again, she wanted to avoid in the first place. So what would you recommend for next steps in management? So this is study 1620. This is a study that gave cemiplimab the FDA approval back in 2021 for advanced basal cell. And this is the only immune therapy that's approved for basal cell. And like I said, it's approved either after failure or progression of a hedgehog inhibitor, or if you cannot tolerate a hedgehog inhibitor. So they had two groups: metastatic basal cell, locally advanced basal cell. They got cemiplimab for almost 2 years, and they were following the cancer by imaging. And here you can see that the overall response rate is lower for metastatic versus locally advanced, which is what we often see, but it's markedly less in squamous cell. Squamous cell, if you remember from one of the beginning slides, immune therapy works, like 50% of patients. This is about a little bit like, roughly half. And the amount of complete responses is less compared to immune therapy for squamous cell. But the responses tend to be durable. So if the patient is responding to an immune therapy drug like cemiplimab for basal cell, it tends to keep the disease under control for a long period of time. So what would you recommend for Linda? Would you switch her to immune therapy? Would you switch her to chemo and radiation? Would you proceed with exoneration, meaning that would you just take her nose out and then give her post-operative radiation, or would you switch to the other hedgehog inhibitor? So I would probably transition her to immune checkpoint because, right, she's on the vismodegib, the hedgehog inhibitor, but the MRI shows that the cancer is growing. So she falls into the bucket of those patients that are now progressing on a hedgehog inhibitor. I probably would not switch to sunitinib because it's a hedgehog inhibitor of it's the same class of meds. So after discussion with the patient and family, she does agree to start cemiplimab. And after 3 doses, you get additional imaging and it shows that the cancer is getting smaller. There's a partial response. And she continues on a therapy for 12 months later, and she still has an ongoing response. The only significant immune-related adverse event that she experienced is hypothyroidism, but that was easily managed with just putting her on a thyroid hormone pill. So in your experience, what are the main barriers to initiating or maintaining immune checkpoint inhibitors for patients with non-melanoma within the VA system? So there are always safety considerations about managing patients on any immune checkpoint inhibitors, whether they're for non-melanoma skin cancer or any other type of cancer where we use these drugs. So these are specific class of adverse events that happen to patients that get immunotherapy. About 72% of patients will have some type of immune-related adverse event. And this is because whenever you're kind of reactivating the T cells to attack the cancer, the T cells can also attack normal parts of the body. But the majority of them occur early on once you start the treatment, but I have seen them happen 1 year later, even after I have stopped the immune therapy. So this is something just to be aware of. But we monitor it routinely because we get blood work on patients each time they get an infusion. They are seen in the cancer clinic by a physician or an APP or a nurse. But most commonly, these immune-related adverse effects affect the skin. They can cause dermatitis and a rash. The gut, they can cause colitis and diarrhea. Endocrine organs like the pituitary gland or the thyroid gland. The thyroid gland is most common. They can also, cause inflammation in the liver and the lungs. So these are just things to watch out for. They happen in they're less common in patients that are much, much, much older. because those patients have less of a robust immune system. But this is something that you must talk about with every patient before starting them on one of these drugs. As you can see here, for the patients that got cemiplimab for squamous cell carcinoma, most of the grade 3 to 4 adverse events, so, ones that are more severe, the percentages are much lower. So it's just something to keep an eye on. It could happen, but they're not super common. And a lot of the times these are very manageable. And then for looking at the same drug, cemiplimab for basal cell carcinoma, we can see that, again, the more severe side effects, the grade 3 to 4, the numbers are much lower, all 5% or lower. And these are all quite manageable as well. So when we think about managing these toxicities, we continue immunotherapy with close monitoring supportive care, meaning that we look at their labs, we examine them in clinic. If they do end up getting a grade 1 adverse event, we will just monitor closely. But if they get a grade 2, sometimes we will hold the immune therapy or ask them to get blood work again and examine them again until the adverse event goes back to a grade 1. Sometimes we'll give them some, oral steroids like prednisone, because, steroids tell the immune system to calm down a bit, and that's what's causing these adverse events. For grade 3, one of the more severe ones, we will hold the immune therapy, and then we typically give steroids at a much higher dose to, tell the immune system to settle down. And sometimes we even have to add other medications that tell the immune system to settle down. Just because you have a grade 3 event does not mean I can't ever give you the medicine again. I just have to be really cautious, and it has to be a discussion we have. And it depends on what type of immune-related event you had. Was it skin? Was it lung? Was it liver? But if you have a grade 4, typically these patients, we will permanently discontinue immune therapy. But there are some, like, the thyroid that is permanent, and it can be severe, but most of the time the thyroid goes back to normal once you put the patient on a like hormone supplementation, and then they're fine. And in those patients, we can continue typically without issue. So, monitoring adverse events requires, multidisciplinary provider roles, because there's lots of things we have to take in consideration, the patient factors, safety profiles, how well do you communicate with your other physicians that can help you? What type of nursing support do you have? Just making sure that everyone is talking to each other to manage these patients. So in conclusions, keratinocyte carcinomas, there's a lot, they're multifaceted, they don't live in a silo. It is best to really get a multidisciplinary care team involved for best outcomes, and this often requires a medical oncologist. We really understand more about the biology of these cancers, which has really led to immunotherapy, changing practice and using immunotherapy earlier in the treatment paradigm, specifically anti-PD-1 immunotherapy, which is already approved for these skin cancers in the advanced settings. And then we also discussed, using these medications before surgery can really help improve outcomes in these patients. And then we're also seeing that maybe it can even help them avoid surgery. So thanks for your attention. I see several questions in the chat. So I will address the first one that I see. So where do you see the use of the new PD-L1 inhibitor cosabelimab fitting in the CSCC treatment landscape? Its studies suggest improved safety compared to PD-1 inhibitors with less immune-mediated adverse events. So this is one of the newest ones. I have not used it yet, and I hope to get more experience with it in the future. But the clinical trial that this drug was approved on, all the sites were not in the US. And so I don't think there's really anyone that has experience with this in the United States. So it's just a drug that we'll just have to get more experience with, but it is an option. I think because it's not a super large study and I don't personally have experience with it, and I don't know many that do within the US, I would have to have experience with it myself before I say that it is definitively a lot safer with less immune-related adverse events. And then why would I choose one hedgehog inhibitor over another? So sunitinib and vismodegib both have the indication for locally advanced disease. Vismodegib has the indication also for metastatic disease. So for metastatic, A lot of patients will choose vismodegib, but if they both had locally advanced disease, you could use either. And so in that case, I tend to prefer sunitinib because the PK profiles of these two drugs are very different to the point where I think myself and a lot of other physicians feel that sunitinib is better tolerated. I'm happy to answer any other questions, or if you guys have any difficult cases that you come across or don't have access to a tumor board, I'm more than happy to, help you guys out. I think you guys have my email. If not, Jen can give it to you. But, we have a lot of new drugs coming out into this space and a lot of different ways to use it. And we've been really able to help our patients, especially our older patients. So thank you.
Thank you so much, Dr. Park. If there's no further questions, we'll conclude for today. I did leave the SurveyMonkey link in the chat, so be sure to fill that out to receive your credit for today. And we will conclude. Thank you so much once again for taking the time to give this talk. We appreciate it. And thank you all for joining. Have a great rest of your day. Bye-bye.